first of all, to make sure, am I audible?
Yes, sir.
Okay, that's great. So I would like to welcome you all to this free webinar, and I'm happy to have you with me today. This is Dr. Muhammad Helmy speaking. I'm the lead mentor of Part 1 MRCOG and Mid-Exam Expert. And today I'm going to discuss with you a very important topic, which is recurrent miscarriage. Actually, I decided to choose this topic because this topic has a lot of discrepancy and controversies between the different protocols, the different guidelines, the different systems or the different countries, and even between the individual doctors in practice and in management and investigations and in everything. But the problem is, and especially in those practicing in the private sector, that we see a lot of doctors who still, ask for unnecessary investigations or prescribe unnecessary treatment for the patient, which put a lot of burden or cost on the patient, and at the end, they are of no benefit. This is a very difficult situation. I know the recurrent miscarriage is one of the difficult problems that face some couples, and sometimes the problem is unexplained, which forces the doctor to try to search for an answer to their questions. That might force any doctor to ask for unnecessary investigations or unnecessary treatment. That's why we need to know what are the UK or the Royal College recommendations regarding this situation or this condition. So the reference of today's session or today's webinar will be the newest Green Top guideline, which was published the last month in June this year. And actually, this guideline was first published in 2011. And since then, they didn't do any update to the guideline until the last month. They have published a new update. So let's see what are the Royal College recommendations regarding this topic or this condition, and to see how can we get benefit from this guideline, not only for the exam, of course, it's for the practice. I prefer usually to practice under evidence-based medicine. That's should be your attitude while practicing. So in this guideline, we will discuss some of the well-known risk factors related to the recurrent miscarriage, and then we will see which investigations can be asked for that particular risk factor and the necessary treatment which can be given to some cases. In the guideline, they have written the risk factors first, then the investigations, then the treatment. No, here I have modified the situation a little bit. I will talk about each risk factor. I will mention the risk factor, then I will mention the specific investigations and treatment needed for that risk factors. And at the end, also, I'm going to summarize to you what are the recommended investigations and also what are the recommended treatment plans. So let's see what we have today. So as a quick introduction, miscarriage is defined as the spontaneous loss of pregnancy before the fetus reaches the viability or the age of fetal viability. And we know that this age of fetal viability can be different across the different countries and different protocols. But in the UK, they define the age of viability as 24 weeks of gestation. So any pregnancy loss from the time of conception until 24 weeks of gestation is considered a miscarriage. And traditionally, the recurrent miscarriage, according to the UK system, has been defined as 3 or more miscarriages. 3 or more miscarriages. To define that woman to have a recurrent miscarriage, she should experience 3 or more miscarriages, which affect approximately 1% of women. But this is one of the new updates in this guideline. We know that there are other guidelines. For example, the American Society of Reproductive Medicine, we know it with the abbreviation, the ASRAM, and the ISHRI, the European Society of Human Reproduction and Embryology. These two systems usually define the recurrent miscarriage as 2 or more miscarriages, not 3 or more, 2 or more. So in this guideline, they make it somehow malleable, They said in this guideline that clinicians can start investigations after 2 miscarriages, if there is any suspicion that the miscarriages are of pathological and not of sporadic nature. So the definition is still, yes, 3 or more miscarriages, but in your practice, if you suspect that the patient is having something pathological, then it's not a wrong practice to start your investigations after 2 first trimester miscarriages. So this is one of the new points which have been updated in this guideline. Also, the definition is not restricted to women suffering with consecutive miscarriages. It's not mandatory that the woman should experience consecutive miscarriages. No, it's about the count of miscarriages. Okay, so if she experienced 3 or more miscarriages, even if these are interrupted by normal pregnancies or by a living baby in between, still, if the patient had 3 or more miscarriages, then you can consider her having recurrent miscarriage. And also, it's not restricted to miscarriages suffered with the same partner, as certain maternal pathologies would be unaffected by the partner. So all we should focus on is the count of miscarriages, whether consecutive or not, whether with the same partner or not. Another important thing to know that the sporadic miscarriage, which most commonly occur in the first trimester, is often the result of random fetal chromosomal anomalies. So when you are asked in the exam as a single best answer question, what is the most common cause of sporadic miscarriage? Of course, it will be the fetal chromosomal anomalies. And the incidence, of course, increases with age. And this affects between 10% and 50% of women aged 20 to 45 years, respectively. So we can see the influence of age on the incidence of the sporadic miscarriage. So that's quick introduction. And let's now talk about the different risk factors which can be involved in a situation like that. Let's start by the epidemiological factors. And here we can talk about the age, the previous history, the consanguinity, and the lifestyle like smoking, alcohol consumption, caffeine, the BMI. All these are called epidemiological factors. As we can see in this table, which is from the guideline, of course, we have different risk factors. Some of them, according to the studies, have shown a strong relation to the risk of miscarriage. Others have not. Like, for example, the advanced maternal age, the paternal age, number of previous miscarriages. If there is a history of previous live birth, as we can see here, no association with subsequent miscarriage risk. The ethnic background, as we can see, the Black ethnic background increase the risk of miscarriage. The consanguinity has no relation to the risk of recurrent miscarriage, but we can see that smoking, excessive alcohol consumption, excessive caffeine consumption as well, and the extremities of the body mass index, like below 19 or more than 25, are related to the risk of recurrent miscarriage. Other factors like environmental chemical exposure and dietary intake, and here they have focused on some elements like the selenium, vitamin D, vitamin B12, for example. All these have limited evidence. Up till now, they need further studies or further investigations to see if they are related to the miscarriage or not. As we can see, for example, here, the advanced maternal age, the more the maternal age, the more the risk of the miscarriage. Like, for example, when the age is between 20 to 24 years, the risk of miscarriage is 11%, while when the age becomes more than 45 years, the risk is about 93%. That's a massive or a significant difference, of course. The percentages, I can say that for part one, they are not that very important to memorize, but this percentage, for example, in part two exam is very important. It's very mandatory to memorize such percentage if you are taking part two exam. Another thing, for example, here, the number of previous miscarriages. As we can see that the more the previous miscarriages, the more the risk of subsequent miscarriage. Like, we can see that the rate of miscarriage or the risk of miscarriage is 11%, 17%, 28%, 39, 47, 60, 63 for women with no 1, 2, 3, or 4, 5, and 6 previous miscarriage. So as we can see, the more the number of previous miscarriages, the more the risk of the subsequent miscarriage. So this is like example of the epidemiological risk factors. And we will now look at if there is any management plan we can do for such risk factors. Of course, for the epidemiological risk factors, we can say that the only thing we have to do is to take a careful history from the patient to know that if she has some of these risk factors or not. So are there any recommendations regarding the management plans for such situation or such problems? Like any problem we can face in different aspects of our practice, there is an important thing we know, it's the lifestyle modification. So is the lifestyle modification in such situations will improve the outcome? Yes. There are some points here, as we can see according to the recommendation of this guideline, that the patient should maintain an average BMI between 19 and 25. Also, the smoking cessation, limiting alcohol consumption, and limiting the caffeine to less than 200 milligrams per day. All these lifestyle modification parameters might improve the outcomes, Most of the studies done on the lifestyle modifications were on sporadic miscarriage cases, but they have concluded that these findings can be applied on also the population suffering from recurrent miscarriage. So that's the first recommendation we have regarding the lifestyle modification. Am I clear so far, everyone?
Yes.
Yes, sir.
Okay, very good. So let's move to the next risk factor we have, which is a very important risk factor. And I know it's might be the first thing that comes to your mind when you face a case suffering from a recurrent miscarriage, that you think that this patient might have thrombophilia, either acquired thrombophilia, which we know as the antiphospholipid syndrome, or an inherited form of thrombophilia. course, the antiphospholipid syndrome is the presence of antiphospholipid antibodies. We know them as the lupus anticoagulant, the anticardiolipin antibodies, and the anti-beta-2 glycoprotein 1 antibodies. These are the laboratory criteria, and along with that, we can have one of the clinical criteria, which is adverse pregnancy outcome or vascular thrombosis. These adverse pregnancy outcomes might include 3 or more consecutive miscarriages before 10 weeks of gestation, or 1 or more normal fetal losses after the 10th week of gestation, or 1 or more preterm birth before 34 weeks of gestation because of placental disease, and mostly it will be a preeclampsia case. So if we have one of the laboratory criteria and one of the clinical criteria, we can diagnose the case as having antiphospholipid syndrome. According to the recommendations of the guideline, the most important 2 antibodies which are related to the risk of recurrent miscarriage are the lupus anticoagulant and the anticardiolipin antibodies. By the way, we have different antiphospholipid antibodies. Those 3 which were mentioned before, the lupus, the anticardiolipin, and the anti-beta-2 glycoprotein 1 antibodies, and there are also other antiphospholipid antibodies, but they are of minor importance. And regarding those 3 mentioned, they found that the lupus anticoagulants and the anticardiolipin antibodies are important, and they are particularly related to the risk of recurrent miscarriage. The studies which were done for the anti-beta-2 glycoprotein antibodies showed some association, but this association which was not significant or not that significant to prove that it has a strong link to recurrent miscarriage. So they recommend further investigations regarding the anti-beta-2 glycoprotein 1 antibody. And what's important for us regarding the recurrent miscarriage cases is to measure the lupus anticoagulant and the anticardiolipin antibodies. So that was the acquired thrombophilia, the antiphospholipid syndrome. What about the inherited thrombophilia? The inherited thrombophilia, we have different conditions like factor V Leiden mutation, protein C and S deficiency, antithrombin deficiency, which is a very rare but very virulent situation, and prothrombin gene mutation. These studies, which were done regarding the inherited thrombophilia, have shown a weak association with recurrent miscarriage. Most of the studies have shown that they are more consistent or more consistently associated with second trimester miscarriages. But overall, still the association between the inherited thrombophilia and cases of recurrent miscarriage is weak, according to the studies, and more investigations are still required. So what are the recommended investigations we should do for cases where we suspect thrombophilia? We can see that in these tables. First, the acquired thrombophilia or the antiphospholipid syndrome. Of course, we have to measure the lupus anticoagulant and the anticardiolipin antibodies. And don't forget that when we measure these antibodies, we have to measure them in 2 situations, at least 12 weeks apart. And we have to see like moderate or high titers for these antibodies. So they are not measured in one situation. No, we have to measure them in 2 settings or in 2 situations, at least 12 weeks apart. And we should have like moderate or high titers of these antibodies to say that there is a laboratory criteria of antiphospholipid syndrome. For the inherited thrombophilia, And as we can conclude from the previous slide that inherited thrombophilia is somehow related to the second trimester miscarriage, but still the overall association with recurrent miscarriage cases is weak. So they say that we can offer, or we may offer, testing for the factor V Leiden, prothrombin gene mutation, and protein S deficiency, which are the most inherited thrombophilias related to, or the most important inherited thrombophilias related to cases of recurrent miscarriages, according to the previous studies, that these factors might be offered, or these investigations might be offered, but ideally within a research context. So it's better if you are going to offer a woman testing for inherited thrombophilia, it should be within a research context. And also, if you are going to ask a woman to do these investigations, you have to counsel the woman that still there is a limited evidence that the treatment will change the reproductive outcome. So for the inherited thrombophilia, you may offer some testings like factor V Leiden, prothrombin gene mutation, and protein S deficiency, but within a research context, and after counseling the woman that the treatment still of limited evidence that it will improve the outcomes. And for the treatment, of course, as we know that the antiphospholipid syndrome has shown a strong link to the cases of recurrent miscarriage, so it's important to focus on the treatment of that situation or that condition, the antiphospholipid syndrome. And of course, the best treatment is the combination between aspirin and heparin. Aspirin and heparin. We can use the unfractioned heparin or the low molecular weight heparin. Of course, according to the results, they have concluded that the unfractioned heparin might be of more efficacy than the low molecular weight heparin. But the unfractioned heparin has more side effects like heparin-induced thrombocytopenia, osteoporosis, and the low molecular weight heparin has a better side effect profile. We can use any of them. We use them from the positive pregnancy test until at least 34 weeks of gestation. So this is for the antiphospholipid syndrome. That's a very important recommendation. And we can notice up till now in the practice, and especially in the private sector, that a lot of cases who are not suffered or are not suffering from thrombophilia, they are being given the aspirin and or heparin as an empirical treatment. And that's a malpractice. If a woman is suffering from unexplained recurrent miscarriage, so aspirin and or heparin should not be given. Okay, so don't give aspirin or heparin unless you diagnose a form of thrombophilia, What about the inherited thrombophilia? We said before that there is a limited evidence regarding the association between inherited thrombophilia and the recurrent miscarriage cases, but some studies have shown a link to second trimester miscarriage. The problem of inherited thrombophilia is not only with the recurrent miscarriage. We have to put that in our mind, that the inherited thrombophilia itself might predispose to thrombosis in pregnancy. So here, your decision to give a treatment or not will be based on the other risk factors the woman has. If the woman is having other risk factors for thromboembolism in pregnancy, you might consider giving anticoagulant in such cases. You can find these risk factors, of course, in another Green Top guideline, which is number 37, which talk about reducing the risk of venous thromboembolism during pregnancy. So for a case like having factor V Leiden, protein S deficiency, or prothrombin gene mutation, you might consider giving the woman anticoagulant if she's having other risk factors for thrombosis and a history of a second trimester miscarriage, especially if she is having an evidence of a placental thrombotic lesion. So these are the recommendations regarding thrombophilia. Am I clear so far, everyone?
Yes, sir.
Okay, very good.
Can I ask one question, sir?
Yes.
Yes, you mentioned that in unexplained pregnancy loss, we should not start the aspirin. And it's for heparin also, right? Both combination should not be started.
Yes, aspirin and or heparin. You should not give anticoagulant to a case just because she's having unexplained recurrent miscarriage, okay?
Okay. And in the, when it is indicated, suppose in case of lupus anticoagulant or any deficiency, if we are finding, then we should start from the start of pregnancy till 34 weeks.
No,
But,
that's for the antiphospholipid syndrome, okay? For the inherited thrombophilia, you are going to calculate the dose and see at which gestation you should start according to other risk factors. This is another topic, which is reducing the risk of thrombosis, okay? That's another topic, okay?
Okay, thank you.
Okay. The next risk factor, of course, will be the genetic risk factor. And here we have either the paternal chromosomal rearrangements or the fetal chromosomal anomalies. For the paternal chromosomal rearrangements, yes, they increase the risk of recurrent miscarriage. And they were found to be associated with recurrent miscarriage, and the translocation was present in 2% of parents after one miscarriage, 4% of parents after two miscarriage, 5% after three miscarriage. That means that the paternal risk or chromosomal rearrangements are strongly related to the risk of recurrent miscarriage. For that, we also have to know that the type of the chromosomal rearrangement itself can affect the risk of miscarriage. As we can see here that, for example, the rate of parents having recurrent miscarriage with reciprocal translocation, inversion, Richardsonian translocation, and other types of chromosomal anomalies have been shown to be 54, 49, 34, and 27% respectively, which means that according to the type of the rearrangement, of course, it will affect the risk of miscarriage. Of course, these definitions, the translocation, inversion, Richardsonian translocation, are all genetic terms, which, of course, will need another session or another lecture to discuss. We discussed that, of course, in the genetics session for the basic science to know what are the meanings of these terms. But what I need you to know that it's not only about the chromosomal rearrangement itself, it's about its type, not about having any random chromosomal rearrangement. I mean, you have also to know what type, because the type itself can affect the risk of recurrent miscarriage. The fetal chromosomal anomalies, we have mentioned before, it's the most common cause of sporadic and also recurrent miscarriage. And they found that approximately 50% of sporadic miscarriages are a result of fetal chromosomal anomaly. This percentage is very important, and it can be a site of question. It can be a matter of question in the exam to be asked about this percentage. 50% of sporadic miscarriages are a result of fetal chromosomal anomalies. And also they found that the incidence of aneuploidy in recurrent miscarriage was found to be approximately 40%, and that's also another important percentage. The incidence of aneuploidy in recurrent miscarriage is about 40%. A very important point here that sometimes when you do analysis of the product of conception to test the chromosomal problems in the conception or the pregnancy tissue, sometimes the pregnancy tissue show that it has an euploid karyotype, I mean normal karyotype, that's actually a prognostic factor for a higher chance for subsequent miscarriage. So that's something, might be against our thinking, that when you think that when the miscarriage or the product of conception after examination, you find that it contains aneuploid chromosomes, that the prognosis is worse. Actually, this is not the case here. When or finding an aneuploid embryo has been found to confer an improved prognosis in the subsequent pregnancy. On the other hand, if the more the number of euploid miscarriages, the higher chance of a subsequent miscarriage. Because here, there is a higher chance of a persistent maternal pathology rather than a sporadic aneuploidy. So most of the cases of aneuploidy are sporadic. So this can give us a better prognosis in the subsequent pregnancy. But when you have a recurrent euploid miscarriage, that all the miscarriage are of normal karyotype, that means that there is another persistent maternal pathology, which will presume that there will be a higher chance of another subsequent miscarriage. Clear, everyone, at this point?
Yes, sir.
Okay, very good. So
Yes,
what are the recommendations regarding this factor, the genetic factor? First, you have to start by doing a cytogenetic analysis of the pregnancy tissue. And this should be done of the third and subsequent first trimester miscarriage, or in any second trimester miscarriage. So if the patient is having a second trimester miscarriage, even it's the first time, you should do cytogenetic analysis. But for the first trimester miscarriage, you can start this cytogenetic analysis if the patient is experiencing the third or more miscarriages. If the cytogenetic analysis of the pregnancy tissue comes to be abnormal or showing what's called unbalanced structural chromosomal abnormality, then at this case, you have to offer peripheral blood karyotyping for both parents. So in a case of recurrent miscarriage, if the cytogenetic analysis comes to be abnormal, showing unbalanced structural chromosomal abnormality, then you have to offer blood karyotyping or peripheral blood karyotyping for both parents. Also, you can offer karyotyping for the parents if the cytogenetic analysis of the pregnancy tissue is unavailable or unsuccessful. If unavailable or unsuccessful. And of course, when you do the peripheral blood karyotyping for both parents and the finding of abnormal parental karyotyping, then you should, of course, refer the couple to a clinical geneticist, okay, for counseling and to see what are the management modalities they can do for their cases. So what are the importance to do this cytogenetic analysis? That's something important in practice to identify the chromosomal rearrangement, to offer the best genetic counseling and the therapies needed for that situation, and also to provide an answer for the couple, okay? Because to not having a diagnosis, this is associated with feeling of frustration and adverse emotions, which are also present in those couples experiencing recurrent miscarriage. So also not having a diagnosis will add more frustration, more emotional bad feelings to them. So it's better to try to give them an answer for their situation, and also to target an evidence-based therapies and reduce the cases which take unnecessary evidence without accurate diagnosis, and also to help in the research trials and to assess the cause of miscarriage. All these are importance of cytogenetic analysis, which can done, as I said, if the first trimester miscarriage is the third or more, or in any case of second trimester miscarriage. So what are the management options? So, for example, if a couple have been diagnosed to have an abnormal karyotype or balanced chromosomal rearrangement. So what are the recommended management plans? Actually, these couples have three options: either to wait for natural pregnancy, or to do what's called ART with PGT-SR, assisted reproduction like XC or IVF, along with testing for structural rearrangements of the embryo. We call it pre-genetic testing, structural rearrangement, PGT-SR, or gamete donation. Of course, gamete donation is not allowed in all countries and in all religious backgrounds. So according to the setting where the couple are found and according to their background, they can do gamete donation or not. Okay, but from the studies, these have shown an equal results at the end to wait for the natural pregnancy and having a healthy baby, or to proceed with ART or PGT-SR. At the end, the outcome is similar. The live birth rates, as shown in the guideline, are similar. So if you are going to counsel the woman, you have to tell her that if you wait for a natural pregnancy, you might get a healthy baby with the same rate if you proceed for ART and PGT-SR. But don't forget that ART and PGT will cost the patient a lot of money, I mean. And of course, she will take a lot of medicine, which of course will have like induction of ovulation. And so, of course, this might have some side effects, like, for example, ovarian hyperstimulation syndrome. So you have to counsel the woman, and she can choose the management option she wants. Also, there is a very important recommendation here in this guideline, that there is insufficient data to support the routine use of pre-genetic testing aneuploidy. A here is the abbreviation of aneuploidy, okay? For cases with unexplained recurrent miscarriage. I mean that if you have a couple who is diagnosed with unexplained recurrent miscarriage, you did the cytogenetic analysis of the pregnancy tissue, it comes to be normal, their peripheral blood karyotype is normal, then don't offer them routinely to do assisted reproduction technique along with examination of the aneuploid status of the embryo, because this will not improve the outcome or improve the rate of the live birth, and also carry a significant cost and potential risk. Carry a significant cost and potential risk. Clear, everyone?
Sorry, that is last point not clear.
I mean that if you have a couple who is having unexplained recurrent miscarriage, unexplained means there is no cause, okay? So don't offer them to do ART, IVF, or XC, I mean, with genetic examination of the embryos for aneuploidy, because this will not improve the outcome at the end. This will not improve the live birth rate. Am I clear?
Yes. Okay.
To wait for a natural pregnancy will give the same result, I mean.
Okay. Thank you.
You're welcome. Okay, so these were the genetic factors. Let's move to the anatomical factors. The anatomical factors. Is there any question? Okay, so for the anatomical factors, we have the congenital uterine anomalies and the acquired uterine problems or anomalies also, like the myoma or the polyps and so on. These are acquired problems, and the congenital one, like the septate, bicornuate, uterus, and so on. So according to the studies done, the congenital uterine anomalies, specifically, I'm talking about the septate and the bicornuate uterus, are linked to the increased risk of first trimester miscarriage. Other studies have shown that the arcuate, septate, bicornuate uterus increase the risk of second trimester miscarriage. So the difference here that the arcuate variety have been added in the second trimester miscarriage. So septate and bicarbonate are linked to first and second trimester miscarriage, while the arcuate in some studies have shown a link to second trimester miscarriage. And of course, the gold standard diagnostic modality of the uterine anomalies is to do the 3D ultrasound, But according to the classifications of many organizations like the ISHRI, the ASTRAM, and so on, they say that or consider that the arcuate uterus is to be a normal variant with no clinical implications. And actually, the studies which were done on the arcuate uterus and its relation to the second trimester miscarriage is not that powerful studies to rely on. So finally, the recommendation is that if you want to deal with a congenital uterine anomaly, which can be linked to miscarriage either in the first trimester or in the second trimester, will be the septate and the bicarbonate uterus, according to the Green Top guideline. For the acquired anomalies or the acquired uterine problems, myomas, endometrial polyps, intrauterine adhesions, up till now, there is uncertain association due to the limitation of the studies and the methodological qualities. Even the studies which were done showing a relation of some of these problems to miscarriage have some bias in the research, have some methodological or statistical problems. So these studies, we cannot rely on them to give an evidence-based recommendation here regarding the relation between the recurrent miscarriage and some of these acquired anomalies like the myoma, endometrial polyps, and intrauterine adhesions. However, there are a lot of studies which have shown that the submucosal myoma can be linked to the recurrent miscarriage, and some studies have shown that resection of these myomas can improve the live birth rate. Also, the the intrauterine adhesions can affect the endometrium for implantation. There is a lack of sufficient amount of normal endometrial tissue. There is a constriction of the uterine cavity. There is defective vascularization. All such pathological implications of intrauterine adhesions can affect the implantation and affect the pregnancy. And some studies have concluded that if there is an evidence of intrauterine adhesions, along with endometrial thickness less than 5 millimeters, this can increase the risk of miscarriage. But as I said, overall, due to the limitation of studies, due to the methodological problems in such studies, we cannot conclude a firm evidence about these acquired anomalies. I can see some of our colleagues are complaining of music. I can't hear anything here. I muted all the participants, by the way, okay? Do you hear any music now?
No, sir. There's no music.
Okay, okay, okay. Okay, so please make sure that there's nothing in your running in the background of your laptop or your cell phone, okay? That might be affecting you. Okay, let's proceed. Let's proceed. Check your laptop or cell phone, okay? You can log out and log in because I don't hear any music, and also other candidates cannot hear any music. Okay, so regarding the cervical integrity, of course, we know that the cervical insufficiency is one of the very important risk factors related to the second trimester miscarriage, and the data from studies on extreme preterm birth, or those cases who had a previous cervical cone biopsy, or those who have an ultrasonographically short cervix, have shown that these cases or these patients have increased risk of second trimester miscarriage. So cervical insufficiency, of course, can increase the risk of second trimester miscarriage, especially if it's associated with infection and congenital uterine anomalies. When do we start the aspirin in cases of antiphospholipid? From the positive pregnancy test. From the positive pregnancy test, I will give time for questions at the end of the session, guys. Okay. So, as a diagnostic modality now, of course, the 3D ultrasound is the gold standard, followed by saline infusion sonography, hysterosalpingography, and lastly, the 2D ultrasound. So, if you want to search for congenital uterine anomalies, then you have to ask for a 3D ultrasound. MRI and endoscopic evaluation should be reserved for complex anomalies when a diagnosis cannot be reached with 3D ultrasound. So the recommended investigation here is the 3D ultrasound. And according to the management, what to do regarding the management of such situation for the congenital uterine anomalies, and here I'm talking about the resection of the uterine septum, can be done, but also it's better to be done within a research context. Some observational studies have indicated that this treatment confers a significant benefit, but there is a lack of randomized controlled trials dedicated to women with recurrent miscarriage. So we cannot say that it's a firm evidence. If you want to do resection of the septum, it might improve the outcome, yes, but it's better to be done within a research context. For the acquired problems, it's better to be done according to the individualized situation, or the treatment here should be individualized according to the case, according to the size of the myoma, for example, according to any other associated symptoms along with the miscarriage. For example, the patient might be suffering heavy menstrual bleeding or any other symptom like pain, for example. So you have to individualize the treatment. Some studies have shown an improvement in the live birth rate with the resection of submucous myoma, but still there is a lack of studies examining relevant intervention. So if you choose to treat an acquired uterine problem, it should be individualized after counseling the patient about the choice of expectant versus surgical options. So this is the anatomical risk factor. For the endocrine factors, we also, this part is very important. We have a lot of points here to discuss. The first thing is that if a patient is having clinical hypothyroidism or diabetes, and if this is not controlled, yes, this might affect the pregnancy and lead to miscarriage. But if the patient is having well-controlled diabetes and thyroid disease, there will be no increased risk of miscarriage. So you have to treat such patients if they are diabetic or having clinical thyroid disease, whether hyper or hypothyroidism. You have to treat them as any patient. And if they are well controlled, the risk of miscarriage will not be increased. A lot of studies have been done on what's called the subclinical hypothyroidism. Subclinical hypothyroidism. And subclinical hypothyroidism, which is defined as TSH more than 2.5 milli-international units per liter, have been reported to be raised in some studies in women with recurrent miscarriage. And also studies on sporadic miscarriages suggest an association. So patient who is having subclinical hypothyroidism, TSH more than 2.5 milli-international units per liter, can increase the risk of recurrent miscarriage. Also, the thyroid autoantibodies, if the patient is having thyroid autoantibodies, this might increase the risk of recurrent miscarriage. The PCO also increase the risk of recurrent miscarriage. Prolactin imbalances, high prolactin, and even in some studies, they have found that very low prolactin levels might affect the pregnancy. These can also be associated with increased risk of recurrent miscarriage, but the luteal phase defect, which means progesterone level in the luteal phase of the cycle, in some studies they say less than 10, or in other studies less than 30. These are still insufficient evidence or inconclusive evidence. So PCO has been linked to the increased risk of miscarriage. The exact mechanism remains unclear, but it's mostly due to the insulin resistance, hyperinsulinemia, and hyperandrogenemia. And also, they found that the elevated free androgen index can be a prognostic factor for a subsequent miscarriage. So what are the recommended investigations? The most important recommendation given here, according to the endocrine factors, is to offer performing thyroid function test along with the thyroid autoantibodies, specifically the thyroid peroxidase antibody. The other endocrine assessments, like diabetes, hyperprolactinemia, should be done only if there is clinical suspicion. Don't do them routinely in any case of recurrent miscarriage. If you suspect the patient is to be diabetic or suspect the patient is to be having hyperprolactinemia from the clinical assessment, then offer the investigation. If not, it's not a routine investigation. But the routine one is to do thyroid function test and thyroid antibodies, specifically the thyroid peroxidase antibody. There is an important thing here to mention that if a woman is euthyroid, means she is having normal thyroid function, but having thyroid peroxidase antibodies positive. She has the antibodies, but her thyroid profile is normal. You still have to offer screening for these antibodies. Why? Despite you will not offer a treatment for such situation, but it's still important that the patient who is having thyroid antibodies will need extensive monitoring of her thyroid function. I mean that if a woman is having a recurrent miscarriage and she has a normal thyroid profile, she has a recurrent miscarriage and she's having thyroid profile normal, you still have to offer the antibody profile, the thyroid peroxidase antibodies. Why? She will not need a treatment because her thyroid function is normal. But having positive antibodies will require extensive monitoring for her thyroid function every few weeks. So you need to offer the thyroid antibodies as a routine investigation in cases of recurrent miscarriage. So what about the treatment? The proven treatment in the endocrine factors is to give, of course, the thyroxine supplementation. I'm not talking here about the patient who is having a clinical hypothyroidism, because these patients, of course, will need the treatment. Here I'm talking about the subclinical hypothyroidism. And actually, they have divided those cases having subclinical hypothyroidism into two categories, mild and moderate. Moderate means TSH more than 4, and mild means TSH more than 2.5 or 2.5. They found, according to the studies, that thyroxine supplementation improved the outcomes in those cases having moderate subclinical hypothyroidism. I mean, when the TSH is more than 4 milli-international units, but not routinely recommended for those having mild subclinical hypothyroidism, TSH more than 2.5, because this will not improve the outcome. And here you should differentiate between dealing with a case having infertility and between dealing with a case having recurrent miscarriage. Because if you are practicing infertility, you will know that if the patient is infertile and she's having TSH more than 2.5, it's better to offer her thyroxine supplementation to make the TSH less than 2.5. This can affect the fertility outcome, yes. But for the recurrent miscarriage group, no. The improved outcomes were seen in those patients having moderate subclinical hypothyroidism, but not for those having mild subclinical hypothyroidism. So it's not routinely recommended to offer them thyroxine except those having TSH more than 4. Also, the patient having thyroid antibodies with normal thyroid profile should not be routinely recommended having thyroxine supplementation. And you have to do regular TSH measurement from 7 to 9 weeks gestation in cases having subclinical hypothyroidism or thyroid peroxidase antibodies. So these are the recommendations regarding the subclinical hypothyroidism. Of course, if a patient is having an overt clinical problem like diabetes, hyperprolactinemia, clinical hypothyroidism, you should treat that as any patient, okay? That management will not be different between a pregnant or an unpregnant lady, because you have to manage, this is a medical disorder, you have to manage it, okay? For the progesterone supplementation, one of the debates, I know that many controversies according whether to give progesterone supplementation or not. According to the studies and the trials done, they have found that the patient who is having recurrent miscarriage and in the current pregnancy, she's having early pregnancy bleeding, you can give her progesterone supplementation at the time of bleeding until 16 weeks of gestation. This can improve the live birth rate. So if the patient is having a history of unexplained miscarriage, of recurrent miscarriage and bleeding in early pregnancy, give her progesterone supplementation from the time she experienced the bleeding until 16 weeks of gestation. This can improve the live birth rate. But routine supplementation of progesterone in asymptomatic women with unexplained recurrent miscarriage should be used with caution. They didn't say it's not recommended. You can use it, but you have to use it with caution, because at the end, it's a hormone, it's a treatment which might confer some side effects. So you have to give it with caution, okay? And also to counsel the patient that most of the trials have shown no significant improvement in the outcome at the end. So that's regarding the progesterone supplementation. Any questions so far?
Yes, Doctor. Can I ask one question?
Yes.
Yes. Just wanted to know that if after 3 consecutive miscarriage or any 3 miscarriage, when we investigate IUD, because when sometimes patient comes and they are in hurry to investigations. So means after 3rd completed miscarriage, means suppose JNC finished everything, then we should wait for 3 months and then we should start all investigations, or immediate after the abortion we can start the investigation.
According to the situation of the case, they didn't specify something regarding the timing to start, except by for the antiphospholipid syndrome or the thrombophilia, you should wait at least 6 weeks after the miscarriage, because pregnancy can affect the result, okay? So you have to wait 6 weeks after the miscarriage, then start the antiphospholipid syndrome and thrombophilia panel. But for other, like for example, if you want to search for a genetic cause, you can start immediately by doing the analysis of the pregnancy tissue, then offer the patient peripheral blood karyotyping according to the results and so on, okay? So it will vary according to which pathology you are searching, because sometimes you suspect a pathology from the history of the patient. So you are going to start to investigate this pathology at first, then you are going to move to other risk factors if you don't find any diagnosis for your first investigation. Am I clear?
Yes. And this test, antiphospholipid antibody test, to repeat after 4 weeks or after 12 weeks?
The antiphospholipid should be done 12 weeks apart.
12 weeks apart.
12
It's
weeks.
3 months apart. Okay.
Yes.
Thank you. Thank you.
You're welcome. I have a question from Dr. Ziad. When to request hysterosalpingography? If you don't have 3D ultrasound and sonohysterography, then you can offer hysterosalpingography, okay? This is the third in the ranking. The first ranking, 3D ultrasound. Second ranking, sonohysterography. Third ranking, hysterosalpingography, okay? That's for diagnosis of congenital uterine anomalies. Okay, let's move to the immune factors. And actually, I will not spend too much time in the immune factors as an explanation for the terms and the details, because that's a pure basic science for immunology. We discussed that, of course, in the immunology sessions for our course, but there are a lot of debates regarding what's called the human leukocytic antigen, or the major histocompatibility complex, the effect of cytokines on the pregnancy, what's called the natural killer cells, whether the peripheral natural killer cells in the blood, or what's called the uterine natural killer cells. These are the natural killer cells found in the decidua or in the uterus. All these factors, or the immune factors, up till now have shown insufficient or inconclusive evidence. So that's why there's the investigations regarding these immune factors are not routinely offered outside a research context, and also the treatments given like immunotherapy and so on are not recommended, but also they carry, by the way, some risks to the patient, so they are not recommended at all. For the infective factors, and that's one of the factors which I can say irritates me a lot when I see patients up till now coming to the clinic carrying a lot of investigations about the torch screening and the infections because they experienced 1 or 2 miscarriages. I say, oh my God, who still do the torch screening up till now? Okay, so the genital tract infection are not related with a firm evidence to cases of recurrent miscarriage. They say that for an infective agent to be implicated in the etiology of recurrent miscarriage, it must be capable of persisting in the genital tract and avoiding detection, or must causing insufficient symptoms to disturb the woman. That's difficult to have a persistent infection in between pregnancies to cause the same problems, which is recurrent miscarriage. And toxoplasma, rubella, cytomegalo, herpes simplex, and listeria are not fulfilling these criteria. Therefore, the routine torch screening should not be undertaken. I'm not against that the patient who suffers an acute attack of infection during pregnancy might experience miscarriage. And by the way, we have seen that during the epidemic of the COVID-19. A lot of patients suffered from miscarriage because they suffered fever and suffered manifestations of infection, so they aborted their pregnancies. Okay, that's something can happen with any infection, like acute infection with severe manifestations in pregnancy can lead to a sporadic abortion, yes. But to make a routine torch screening for cases with recurrent miscarriage, this is not logic, because this infection, even if it comes to a patient in one pregnancy, it will not be persistent. The patient will have immunity after that. And even I still get surprised when I see that the patient is having like cytomegalovirus IgG positive, which means that she's having an immunity against the virus, or toxoplasma IgG, and she's taking treatment for that. So why are giving her a treatment? Because she is immune? No, that's not a good practice. That's not a good practice to give patients unnecessary treatments. Okay, but as I said, usually some doctors try to give the patient any answer to satisfy the patient at the end. But I don't prefer that. Of course, you have to be honest with the patient, and you have to practice according to the evidence-based medicine. So there is insufficient or inconclusive evidence regarding the genital tract infections. There are some studies which have shown that bacterial vaginosis might increase the risk of second trimester miscarriage. But there is also a lack of data regarding the recurrent miscarriage population, and also chronic endometritis have been implicated in some studies in some cases of recurrent miscarriage, but the diagnostic criteria of chronic endometritis still controversial, whether to do it by histopathology or to do it by molecular techniques and so on. There is a debate according to regarding the diagnosis of chronic endometritis. So at the end, we cannot say that we have a firm evidence regarding the association between infection or genital tract infection and recurrent miscarriage population. But of course, if a woman is pregnant and she's having an acute infection, you have to treat that. For example, if the patient comes to you in her first trimester, she's suffering from the bacterial vaginosis. She's telling you that she is having a discharge, which is a very offensive in odor and fishy in odor and so on. You have to treat that. Don't say that it's not related to the miscarriage, so I'm not going to treat that. No, you have to treat the infection, of course, but don't offer screening for these infections because a woman is having recurrent miscarriage. Clear, everyone?
Yes, doctor.
Okay. So, women with recurrent miscarriage should not be routinely offered infection screening outside of the research context. If you are going to do that, this should be done within a research context, okay? Not routinely for patients. For the male factor, and this is the last factor we are going to discuss for today, a lot of parameters are examined in the semen analysis, and some of them have shown a link to bad obstetric outcome. But the most common one linked to the recurrent miscarriage group is what's called the sperm DNA fragmentation or the sperm DNA damage. The more the DNA damage, the more the risk of recurrent miscarriage, the more the risk of recurrent miscarriage. What is the etiology of sperm DNA fragmentation or sperm DNA damage? The exact etiology is not known, okay? But there are some lifestyle problems like smoking, exposure to pollutants and so on might increase that. So in some men, these lifestyle modification, like smoking cessation, weight loss, exercise, avoiding or reduction to exposure to pollution, this or also taking antioxidant therapy in some cases or in some studies have shown some improvement, but these are limited studies, and we cannot rely on that to say that these parameters or these management modalities can improve the sperm DNA fragmentation. Of course, those people or those colleagues who are working in the field of infertility know this problem a lot, the sperm DNA fragmentation, and such patients, might need, when they do like assisted reproduction, like XC or IVF, sometimes we need to take the biopsy from the testicles or from the testis, to take sperm from the testis, not from the ejaculate, to get like a fresh sperms without much DNA damage, okay? But this is not our scope for today's session. We are talking about miscarriage group. So these modalities of treatment are not showing a firm evidence to improve the condition. That's why we do not recommend routine sperm DNA testing for patients with having recurrent miscarriage, although we know it might be related to couples with recurrent miscarriage. But offering, when you offer an investigation, you should offer that because you have a treatment for that. But if you don't have a firm treatment, then sometimes the investigation will not be useful for you or for any benefit for you, okay? So the lacking of data regarding the treatment, as mentioned in the guidelines, although there appears to be an association between the sperm DNA fragmentation and miscarriage, there are yet to be any prospective trials demonstrating improved outcomes with intervention. So if you are going to offer sperm DNA testing, it should be also within a research context. For those women who have unexplained recurrent miscarriage, there are two suggested treatment or management modalities. Some studies have suggested the endometrial scratch. Endometrial scratch means to do endometrial trauma by using a people or something before the pregnancy. This maneuver have been tried a lot in the field of infertility in those women having what's called recurrent implantation failure. If you do implant transfer many times and there is no pregnancy, a lot of studies have been done regarding this endometrial scratch, do scratching for the endometrium before transferring the implants. Some studies have shown improvement in the outcomes, other studies have not. At the end, also, there is no firm evidence of the benefit of the endometrial scratch in the field of infertility and also in the field of recurrent miscarriage or in the aspect of recurrent miscarriage. So it's not recommended. But women with unexplained recurrent miscarriage should have supportive care. In a dedicated recurrent miscarriage clinic. They should go to a dedicated clinic and they should have psychological support, counseling, and studies, by the way, have shown improvement in the outcomes or in the pregnancy outcomes after the reassurance and psychological support. And of course, here I'm talking about those women having unexplained recurrent miscarriage. So to summarize at the end, what are mentioned in this guideline regarding the investigations and the treatment, that's what matters all of us when we practice. Then we have a case in your clinic or in your hospital having recurrent miscarriage, the things you are thinking about is what to request for them as an investigations and what to avoid, of course, what treatment to be given, what treatment to be avoided. So we can say that the recommended investigations, of course, to test for the antiphospholipid syndrome, that's a recommended investigation, to do a cytogenetic analysis on the pregnancy tissue of the third and subsequent miscarriage and in any second trimester miscarriage, then to offer parental peripheral blood karyotyping if the testing of pregnancy tissue reports an unbalanced structural chromosomal abnormality or is unavailable or unsuccessful. Okay? You have to assess for congenital uterine anomalies with 3D ultrasound, and you have to assess the thyroid function test and assessment of thyroid peroxidase antibodies. These are recommended investigations. Other investigations which can be done but within clinical research to offer the thrombophilia panel, factor V laden, prothrombin gene mutation, and protein S deficiency, the immunological screening, and the infection screening and the sperm DNA testing. These testings should not be routinely offered. If you are going to offer them, it's better to be offered within a research context. And for the thrombophilia panel for women with mostly with the second trimester miscarriage, because as we mentioned before, thrombophilia is more related to the second trimester miscarriage. What about the recommended management plans? The lifestyle modifications we have mentioned to maintain a PMI between 19 and 25, smoking cessation, limiting alcohol consumption, limiting caffeine intake, to give aspirin and heparin from positive pregnancy test until 34 weeks of gestation in cases to antiphospholipid syndrome should be offered to women with antiphospholipid syndrome and could be considered for women with inherited thrombophilia like factor V laden, protein S deficiency, prothrombin gene mutation, when there are risk factors of thrombosis, when there are other risk factors for thrombosis, and you can know the other risk factors from the Green Tube Guideline number 37. Also, you have to offer the woman who is having, the couple who have chromosomal rearrangement, the three options: the natural conception or PGTSR, the pre-genetic testing structural rearrangement, or gamete donation. And you have to counsel them that the results of the three modalities are the same, so they can choose. They can choose at the end. Other recommended managements: the resection of a uterine septum for recurrent first or second trimester miscarriage, but better to be, or ideally to be within an audit or a research context. But if you do it, as I told you, other studies have shown improvement in the outcomes. So if you do it, it's not a malpractice, okay? It's not necessary to be done within a research context. They say ideally. So ideally means that it's better to be done within a research context. But if you do that, and woman is having septum, and you do a septum resection, some or a lot of studies have shown improvement in the outcome, so you can consider that. Thyroxine supplementation for moderate subclinical hypothyroidism, more than 4 milli-international units, to treat the clinical hypothyroidism, thyrotoxicosis, diabetes, hyperprolactinemia as any patient, and to give the progesterone supplementation in a woman with recurrent miscarriage and bleeding in early pregnancy. So these are the recommended management plans. The management plans with no evidence or not recommended at all are to give aspirin or heparin in women with unexplained recurrent miscarriage, to offer BGTA for couples with unexplained recurrent miscarriage, to manage acquired uterine anomalies routinely. You have to counsel the woman and to individualize your treatment, to give routine thyroxine supplementation to women who have normal thyroid profile and positive thyroid antibodies, or to those having mild subclinical hypothyroidism. That's not routinely recommended. Immunotherapy not recommended at all. And there is no evidence to recommend treatments for male factors, specifically the DNA fragmentation, to improve the recurrent miscarriage outcomes. So these tables summarize what are the important investigations, what are the important management plans, what to avoid also regarding investigations and the management plans. And by this, we come to the end of this webinar. I hope you enjoyed it. If you have any question, any comment or feedback, please do ask me and I will be happy to answer your queries. Any question?
And Dr. Muhammad, for a case of euthyroid, even if the thyroid function test you mean normal, but there is positive antithyroid, in such case we should use thyroxine for recurrent miscarriage?
According to the recommendations, no, you should not do it routinely, okay? I know that most of the physicians prescribe, okay? Especially if you are dealing with a patient who has a history of infertility, okay? But according to here, usually the recommendations comes from studies, and studies have compared groups having positive thyroid antibodies but normal thyroid profile, and they give them thyroxine. There's no improvement in the outcome, okay? But in such situations, we know that the antibodies might affect the thyroid function, might lead to hyperthyroidism or might lead to hypothyroidism. So you have to monitor the thyroid function regularly. If there is any change in the thyroid function, then you have to manage. Okay. This was yes.
Is it subclinical hypothyroidisms with antibody, or it is euthyroid with antibody?
If it's euthyroid with antibody, okay, you should not offer treatment. Okay. If you have subclinical hypothyroidism, here they mention in the guideline, irrespective of the thyroid antibody status, you have to see if it's mild or moderate. If it's moderate, means that the TSH more than 4, you should offer treatment. If it's mild, more than 2.5, the treatment will not improve the outcome. So it's not routinely recommended, irrespective of the antibody status. Okay. Did you get the point?
Yeah, I get it. For a subclinical hypothyroidism. But for
yes.
EO, still confusing.
For euthyroid and antibody positive, you don't have to offer treatment because the treatment will not improve the outcome. Okay.
Okay, thank you.
You're welcome. Dr. Simon is asking which year this guideline was revised. This was published the last month, this year, in June 2023. Okay. So it's a fresh guideline. That's the most recent guideline for the green applications.
Dr. Muhammad, another question. But as we know, it's for recurrent miscarriage, usually it is sequential miscarriage.
No, they have modified the you mean consecutive, yes? No, they have revised the definition. They said that it should not be restricted to consecutive miscarriage. It's now about the count, even if it's not consecutive, even if it's not with the same partner. Okay, so if she has one marriage and she has one miscarriage in her first marriage, and then she's married again, okay, and she has 2 or 3 more miscarriages in her second marriage, it's still considered, recurrent miscarriage. Okay.
Yeah.
Sorry, doctor, I got disconnected. So I was asking, in first trimester, the cutoff for the TSH level should be less than 2.5. And if suppose it is more than 2.5, and antibody is positive, we should treat the patient. But here,
no, we have 2 categories: euthyroid or having subclinical hypothyroidism. Okay, if you have subclinical hypothyroidism, you will not focus on the antibody status. Okay, it will be irrespective of her antibody status. You will have to categorize her as mild or moderate. The mild, which means TSH more than 2.5 but still less than 4, this category don't require routine treatment because the treatment will not improve the outcome at the end. But those with moderate, I mean TSH more than 4, they require treatment because the treatment can improve the outcome. For those women having normal thyroid function with positive antibodies, also they don't have to take treatment because the treatment will not improve her outcome. Okay.
Okay.
Hello,
Dr. Hassan is out. Yes.
Yes, please. Thank you very much for the lecture. My question is about vaginal pessary. That's cyclogest now. What is the recommendation? Because I think I read somewhere that vaginal pessary could be given, especially in recurrent miscarriages, up to 16 weeks. I don't know. Can you shed more light on use of vaginal pessary in
yes.
miscarriage?
Yes, I understand your question. Yes, for the debate of progesterone, we know that if any woman is coming now to any doctor in his clinic and having recurrent miscarriage, whether unexplained or not, he usually prescribes progesterone. So the recommendations were done on the progesterone that if the patient is having recurrent miscarriage and she is experiencing in her current pregnancy now, she has a history of previous recurrent miscarriage, and now in her current pregnancy, she's experiencing early pregnancy bleeding, like threatened abortion, for example. Okay, so such patients might benefit from giving her progesterone supplementation, like 400 microgram micronized progesterone vaginally from the time she experienced the bleeding until the end of 16 weeks. This can improve the live birth rate, okay, improve the outcome at the end. But if the patient is having unexplained recurrent miscarriage, unexplained, we don't have a specific cause, and at the same time, she's asymptomatic, she has no symptoms, they say that giving a progesterone here is a debatable issue, and if to be used, it should be used with caution, okay? Clear?
Thank you very much. Yes.
You're welcome. There is one colleague who tried to ask a question, I think, but your internet is, I think, weak and your voice is interrupted. So if you don't mind, please, can you write your question in the chat? You are most welcome, everyone. Thank you. You can give 400 micrograms, okay? Up to 400 micrograms. Sorry, I mean 400 milligrams, not micro, milligrams, 400 milligrams, I mean. The same, it's vaginally, okay? Vaginally or rectally, you can give that or that. Thank you so much for your kind words, everyone. Thank you. Any more question?
Sorry, are you going to give us this slide?
This session is recorded, okay, and you can find it on our YouTube channel at any time. You want to revise or you want to listen, you can see this lecture on our YouTube channel on the Med-Exam Expert. Go to the YouTube and search for Med-Exam Expert. You're going to find our YouTube channel. Subscribe, of course, to see any new videos there, and you are going to find the recording there. Okay.
Thank you.
Yeah. Okay, everyone. Thank you so much for attending this webinar. I was glad to have you with me in this session. Dr. Ziada, another question. Okay, what about cervical cerclage? Oh, this is another guideline. Okay, we will not discuss cervical insufficiency is a separate guideline. Okay, we might consider doing another webinar about cervical cerclage and insufficiency. Okay, but this will need another session. So that's why we didn't discuss today. When do we do HCG urine and serum? It's nice to see you again. Nice to meet you also. And we wish to see you again in other webinars. When do we do HCG urine and serum, Dr. Arud? I don't understand your question. What is the relation of HCG in urine and serum regarding miscarriage? You mean after miscarriage? Another question, what about HCG? What is the relation of HCG? You mean HCG about the investigation HCG or to give HCG as a treatment? I don't understand the question. Please clarify. This guideline is 2023, last month, okay? Very fresh. No, there is no benefit from measuring the HCG in threatened abortion as long as you see a sac, you see a pulsation. So what is the benefit of HCG serial measurement? You can do that if the patient is having complete abortion and you want to make sure that the HCG becomes negative, then you have to do it 3 weeks after abortion, for example. Okay. Okay, waiting for more questions. Any more? Okay, I have to end now. Thank you so much, everyone, for attending the webinar. I was glad to have you with me today and looking forward to meet you again in other webinars. See you. Bye-bye.